until Rick Saunders up here, I'm sitting up here with two of the busiest emergency physicians I've ever met. These guys are on the road all the time, yet they're the most productive physicians. They publish articles. They're former presidents of ACEP. They're invited keynote speakers in different countries around the world. And the question would be, how do such talented people have time to keep up with the literature? And I would ask that question to Greg and Billy. What resource could you possibly use in your busy lives to keep you up and abreast of all the recent advances in medicine?
Well, I'm glad you asked that question, Dr. Sacchetti. And of course, it's the abstracts and MRAP.
All right, since I'll make my declaration, since I work for one of those companies, there's also the Journal Watch. There's also a variety of other locations like the LLSA. I think the important thing is just to stay engaged in the process. And I see people who become disengaged every once in a while, even in residency. I mean, it's hard to imagine that someone in residency would be sort of on the senioritis and disengaging, but you just can't disengage.
Yeah, but only one publication has a picture of an incredibly good-looking guy on the cover of it.
Mel Herbert, right?
And, yeah. No, the guy next to Mel. I mean, it's, you know, there's a lot of you who might want to take this home and put it up, you know, in your the locker room at the ER or whatever. Actually, out in the desk out front there are some handouts for a number of outstanding publications. How many people here subscribe to EMA abstracts? Yeah. How many people subscribe?
Not that many. Usually it's more than that.
Yeah, MRAP. I mean,
MRAPers?
Yeah.
rapping?
Yep.
Yeah.
Bottom line is these things are two of the probably the best.
Like you're on commission? You
I'm not getting any commission. No, that's why I can do the commercial.
That's why he's doing it.
Yeah, I'm the I'm what's the name? The independent contractor here. The bottom line is emergency medicine abstracts. 40 articles every month. They go through the articles. You get a CD. You actually get 2 CDs. You get to listen to them. You listen to Rick. Sometimes he has a guest on there, which is Billy on occasion. Most of the time it's with Jerry Hoffman. They'll go through the articles. It's kind of like, how many people ever heard Car Talk on NPR? And it's kind of like, you know, Car Talk goes to the library type of thing. They usually give a very interesting impression of the articles. Each issue comes with a very succinct essay, written generally by Dr. Bukata. And you can get CMEs and all kinds of other good things with it. You can even, if you're interested, watch it on the iPods downloads and stuff. So it's actually very good. MRAP is, this is Mel Herbert's thing, which is actually formal lectures, many of which are given by Billy. I've heard Billy on here a number of times, and I've heard Greg on there a number of times. Basically recorded at different conferences around the country, ACEP, AAM, a number of different conferences. Excellent talks.
A bunch of university grand rounds. So he'll pick up university grand rounds from Temple, from Harvard, from Ottawa, from our place, and then sort of pick at them a little bit, which is fun. Yep.
But if you're wondering, the articles that are in your books, they all come from emergency medicine abstracts. So it is worth getting. And I recommend at least getting a CD on the way out. Take a listen to it.
The most useful thing about Emma for me is you're working and you're having a problem with somebody who wants you to do X, Y, or Z that you really don't want to do or that you think is a bad idea. And invariably, before you start calling each other names, someone will say, well, I think it should be done this way. And, you know, they'll have some vague reference and you'll say, well, I'm pretty sure that the information suggests the opposite. And what happens is finally they'll say, all right, I'm coming in. And by the time they come in with a 2-second search on Emma, I can download 6 abstracts that have my point of view. Here. Yeah. And you don't have to hit, you know, it's the age-old thing. When you roll up the newspaper, the first time you roll up the newspaper, you actually have to hit the dog with it. The next time it happens, you just have to roll up the newspaper and the dog is quiet. And so the abstracts are an excellent example of that, where you can just shut stuff down with information, and if you've got a printer and a computer available to you, you can just boom. You can just search a simple topic, whip down 4 papers and say, no, that's not what's done anymore. Yeah.
Not only that, it's usually in their literature. It searches the literature that we don't read. I mean, I just don't have time to read the Journal of Urology these days, so.
It's like 800 papers, or 800 journals, right? Is that what it is? What current?
It's around there.
The articles all come from the search of the weekly current contents in medicine in English. And Rick and Jerry talk about wanting to kill you.
Okay.
Without getting into shameless self-promotion here, let me raise what I think is the most difficult question for the residents getting out, and that is it's information overload. How many people here have journals around the house that they've said they're going to read? Yeah, well, of course. This is what I call stacks and stacks of guilt. Yeah. And they pile up. Do me a favor, go home and throw every one of them out. And then what you do is discipline yourself. Very smart old guy when I was in med school said, Greg, if you read a half hour a day, you'll be ahead of all of us. He was exactly right. What you need to do is have sources you trust that you look at on a regular basis and in limited time, bang for the buck. And if you don't do that, then you will fall off into nothingness, and then you just have magazines stacking up that you're never going to look at. But I think it is that rigor, that intellectual rigor, which is really the toughest thing to accomplish. Everything's easy when you're a resident. When you're now married, you got 3 kids, a mortgage, somebody wants to go on vacation and your kid's got a basketball game tonight, that's when looking at the literature gets tough, in my opinion. That's the real test of a doc.
All right, let's jump in. Yep.
So this is a medical legal section here, some selected topics to talk about, and we couldn't have more authoritative man than the editor of ASEP's book. What is that book called? Risk Management and Emergency Medicine?
Yes, exactly.
How about that? Greg's the editor of that. He has probably reviewed more cases than any human being on the planet relating to emergency medicine for the last umpteen years. So we're kind of fortunate to have Greg.
That's a mixed blessing to be known as an expert on screw-ups. It's either you're an expert because you come in and you clean them up, or you're an expert because you've done so many of them.
You've caused so many of them yourself, right? Yeah.
Matt, is his mic? Are these mics on? Yep. You can hear in the back. Okay. So the first section talked about quality care, standard of care, physician experience, those kinds of things. The first paper that's there, I alluded to yesterday when we talked about hip fracture care. This is actually a broader look at, are people getting care that is expected of that they should be getting? So this is that RAND study we're talking about, where they looked at these 30 chronic conditions, 439 indicators, and said, let's look at the care of a bunch of people and see whether they're getting what they ought to be getting, at least as defended by the literature. And depending on what they were looking at, we mentioned yesterday, 20 to 30% of the people who had hip fractures were getting what they ought to have been getting. And this paper showed that it was about 55% overall, with regards to 55% of the things that should have been done for these conditions were being done by the doctors who were treating them, from prostate hyperplasia to GI things to hip fractures, you name it, they looked at it.
But they weren't very controversial things, right? These were all things that everyone would kind of agree on. You got coronary artery disease and you've had an event, you should be on aspirin. So it wasn't like you should be on Plavix where we could argue about it. These were really straightforward things. There were 439 indicators, but they were things that would have a high level agreement among the group here in terms of their general level of indication. Most everyone would say, yeah, they should have that. And this was a Herculean data dredge. 13,000 patients, and they just said we're not doing that good a job. I mean, this is one of these classic doctor bashing papers that said when you look at even simple, well agreed upon things, care often falls off the mark.
What's very interesting is when you actually look at the papers on who did better at what centers, particularly in things like cardiovascular disease, the difference between the smaller hospitals and the outlying hospitals and the major centers is not in their ability to get you to the cath lab. It's in doing things like beta blockers.
Aspirin and beta blockers.
Aspirin and beta blockers and heparin and a few things like that at certain moments in time. It's simplicity that wins. And we're really talking in most of these things of very simple ideas. The concept yesterday with the hip fracture, there is no question that if I have my hip broken, and I'm heading toward that age range, folks, it's going to happen, I want to be taken care of in the next 15 hours. I want that thing pinned. I don't want it at 48 hours. Why? Because it triples the number of PEs, your postoperative infection, all these things. We're talking about absolute simplicity here, and we're not good at simplicity.
You know, a lot of doctors don't like these papers where we kind of look at, could we do better? But the fact of the matter is that when you look at the literature says, here's stuff, we think it's good, here's the evidence to support it, here's 10 papers, and we have this hard time embracing all of this stuff and incorporating it into our practice. One of the papers we did very recently on the primary care side said, yeah, these great guidelines are great. And you want us to do these 5 or 6 or 7 things for diabetic patients. But the fact of the matter is that these diabetic patients are also hypertensive patients. These diabetic patients are also hyperlipidemia patients. And when they look at the elderly people, they often have 4 and 5 chronic diseases. And
all of which has its own guideline.
Right. They basically conclude that you will be doing so many kinds of things to take care of these patients that you'll not be able to care for them all, because all of these guidelines will be added to each other. Some of them will conflict with each other.
Yeah, conflict with them.
Because whenever they talk about guideline-related care, they think you're treating one condition, and they don't take into consideration that our family practice colleagues in the next room have got a lot of patients who've got a lot of concomitant problems. But the point is, this is about screw-ups and malpractice and not giving patients what they're supposed to get. So this sets the tune that a lot of people are not getting what they're supposed to be getting.
But if you're looking at, if the question is, what's the standard of care? The standard of care is what the average garden variety emergency physician does, and Greg can I guess, talk specifically about the term standard of care. But if you're looking, what's the average doc do? The average doc screws it up. So it's like...
yeah, so take heart. You'll be okay. Yeah. Someone can defend you no matter what you do.
Yeah.
No, I mean, if you're looking at the standard of care says medicine is getting so complex that the average doc cannot manage all these problems effectively.
I like paper 3. You want to be entertained. And, you know, the residents, I hesitated to let the residents see this one. The residents will sometimes bark that some of our attending staff have gotten behind. That some of the attending staff have their pet peeves and their projects of which they know very well, but they haven't really kept up in general. And so there's this concept where we like to believe that, and I can remember, in fact, I remember a surgeon throwing the instruments against the wall and yelling at a resident saying, you find someone with gray hair or no hair to tell me what this bullshit means. Meaning that the senior doctor would know best. Well, Abstract 3 says not so. Says that in one large study there was a 0.5% increase in patient mortality for every year since the treating physician graduated from high school, from medical school. So that from the day you graduate, your care gets worse and worse and worse. And in fact, at the board exam, we know that the failure rates for the emergency medicine board exam just had a big increase. Why? The third-time recerters are now in the pool. And they just can't pass the exam on the third time. And so this concept that you'll be better and better and that you'd like to think that you're getting smarter in medicine is pretty challengeable. This is 59 studies that evaluated knowledge, guideline adherence, and some other quality of process.
But there's part of the problem. There are very few of the studies looked at outcomes. A lot of the studies looked at, geez, these older docs don't adhere to new guidelines. Well, part of the experience was the guidelines sucked. And the other is, a lot of these people get clinical experience as they get older. If you look at the textbooks, the textbook says, someone comes in who falls on their shoulder, you feel a deficit in their glenoid fossa, you should get a shoulder x-ray on them to see what the damage is done. Most of the docs in my department will just put the shoulder back. They give them some 75 of propofol, 100 of propofol, put the shoulder back in, and then take an x-ray on them to make sure there's nothing else going on. You would, if you did the chart review, you'd say, these people, how stupid could they be? They're reducing shoulders, they don't even know what's going on there. Clinically, they know the thing's dislocated. There's lots of times that people have enough clinical experience, they don't follow the guidelines. Number one, because they get the outcomes better. There's a great study on the pediatricians, what they called it was pediatric research in the office setting. It's a PROS study. And what they did is they looked at how these pediatricians managed febrile neonates, kids less than 28 days of age with a fever. Every protocol in every residency around the country says you need to do a full septic workup and admit somebody under 28 days of age. Even the Philadelphia protocol says you can't send those kids home. These guys just looked at the kids and said, I think this one's sick, we're going to admit this one, I'm going to do a septic workup on this one. Did almost no septic workups, and they got it right 100%. They missed one urinary tract infection. Now, if you looked at it, you'd say these guys are not practicing
They're
good medicine.
flying by the seat of their pants, but they flew pretty well.
Yep, exactly. So you got to be careful. The studies that worry me are the ones that actually look at outcome, where you say, yeah, these patients are dying the longer people have been out of practice.
That's why I quoted this one, a 0.5% increase in mortality per year out.
The only question becomes, as you get older, your patients age as well. So if you're looking at a primary care setting, you're basically, your patient population ages with you. Maybe they're getting older as well.
Well, that might be true, particularly in office settings where people choose, but I don't think it's true in the emergency room.
Not in the emergency room.
I don't think it's true in the emergency room.
The older people look when they go, hey, you ought to see Mallon over there. He's about the same age as you, and oh, you look pretty young. You ought to go see one of the residents.
Yeah,
and then there's all these papers about whether the patients like us.
Yeah, well, there's always going to be controversies. Let me just say this. Whenever you decide to come up with a guideline that people follow, within the profession itself, there's going to be an argument about whether that has any validity. I think the aspirin argument is over now. We all believe in that. There's going to be nobody on this panel who's going to fight with you. If you talk about doing the pulse ox immediately on a pneumonia patient, or that the blood culture not done within such and such a time period, you know what? We could have a fight right here about that. And yet now, it is a guideline by which not only are you supposed to follow it, but which your hospital can get dinged on its payment based on that. And a lot of that's irrational. I mean, just because someone's come up with a guideline does not mean it guarantees better outcome.
We're going to talk about the guidelines a little bit further, but the first three papers basically are to make the case that a lot of people are not getting the care that they ought to be getting. If you look at number one, number two is these are doctors who are deliberately deviating from what they're normally doing in terms of quality care. And they said, why are doctors deviating from what they normally do with regard to quality care? And they did the survey, and the doctors, yes, they did acknowledge that in these cases, I did deviate from what I would normally do. And they said, what were the reasons that these doctors deviated? And a lot of the reasons were kind of like social reasons, in that when they looked at the most egregious deviations from what they thought would be reasonable care, they said, why did that happen? Because I was getting into a conflict with the patient, or there was some issues regarding of trust in the patient that was coming up, or I wanted to preserve a working relationship with the patient, so I didn't press them to get this test, which I would normally have done because they didn't want to do it, and we were getting into an argument now over this thing. So they acknowledged that a lot of times they don't do the things that they ought to do for reasons which are not necessarily focused on medicine, but are more related to other issues.
And might be good reasons.
By the way, whenever we talk about standard of care, what we're actually saying is this, and this is the legal definition in all 50 states and territories of the United States: that which a physician of like or similar training would do under like or similar circumstances. So by definition, if you are following the standard of care, there's never going to be any progress. See, the important thing is if you're going to deviate from the standard of care, you do so in some sort of research protocol. Whenever we decide to do research, that's why we go to a committee at the hospital to say we have decent ideas that it ought to move in this direction, and we're going to do a systematic deviation from the standard of care, looking at a particular question. That's called research. If you've just decided to deviate on your own from the standard of care, that's called dangerous. And you need to keep those concepts separate. By the way, standard of care is not one thing. It may be a series of things. You know, I could give you an infection and we could come up with 5 different antibiotic regimes, all of which would be standard of care. It's not one thing, but it's what a reasonable physician would do under like or similar circumstances. And by the way, each one of us practices in a different area. If you've got a neurosurgeon on staff, maybe the reasonable thing is to call down the neurosurgeon. If you don't have one for 80 miles, then it might be really quite something different.
The other thing is that if in a trial, a jury trial, a jury is allowed to say, yep, that's a standard of care, but we think that the standard of care is wrong. They did it with for years, the standard of care for a subarachnoid hemorrhoid, yeah. If you got a subarachnoid hemorrhoid, you got a problem.
Well, what you'd have is your head up your ass.
Yeah. Right. Subarachnoid hemorrhoid.
Yeah. It's true, you would.
So
go ahead.
The concept is funny.
Yeah. In fact, there's probably a lot of administrators who probably have that problem. you have a subarachnoid hemorrhage.
No, they have subarachnoid impaction.
Yeah, that's true. If you have a subarachnoid hemorrhage, the standard of care used to be wait 2 weeks before you went in and repaired it. And then a lot of people would rebleed and get into trouble with that, and they would sue the neurosurgeons. And what they said, a number of the jury said, when the defense would get up and say, "Yep, this is the standard. We always do that." They said that may be the standard, but it's not the best thing for the patient. And they ruled against these people. And ultimately, that was one of the things that helped move it to the immediate intervention stage.
So the idea is to acknowledge that doctors make mistakes for a variety of reasons. Sometimes they willingly make the mistakes. Sometimes they're not aware of the mistakes that they're making. Sometimes as they get older, their knowledge base does decline. That's a fact. I mean, they looked at the scores on internal medicine recertification exams. The older you are, the worse you score. So your factual database goes down. And then you add in number 4 here, which is some issues regarding how you're reacting with your patients from a interpersonal point of view. This is a study where they looked at women who had recently delivered babies and presented them scenarios and what was their likelihood to sue if the baby had a bad outcome. There's a theoretical scenario. Basically, they showed them some issues regarding communication. They were much more inclined to sue in bad outcomes when there was poor communication. They didn't like the doctor, those kinds of things. So it is kind of the potential for a perfect storm in terms of there's a lot of stuff that we're supposed to know. A lot of the reaction to us relates to how we react to patients, because you all know doctors who are criminal doctors in terms of their ability to care for people, but their patients love them. And to the extent their patients love them, they will never bother, that those doctors can sail along doing things that were basically medically inappropriate for a good part of their career because they've got such good skills at making it clear to the patients that I'm going to take care of you, I'm your doctor, we're going to take, those kinds of things so that the patients don't sue them, but you know who they are kind of thing.
Yeah, sometimes when you're in the emergency room and you get this person who says, well, my doctor's Dr. So-and-so, you don't even need to go further. That doctor has attracted every squirrel within 300 miles there.
Right.
You know immediately, just when they proudly proclaim who their doctor is, that they're a squirrel.
They've got reflex sympathetic dystrophy, fibromyalgia, chronic fatigue.
And by the way, you never see anything rude about anyone else's doctor. Now, I'm a believer in the immortal soul. I do not think you should lie. But you don't have to necessarily play total truth at this moment either. And I can always say something reasonable about everybody. If they say, well, my doctor's Dr. Smith, and let's say he is dumber than whale poo-poo and does weird things, I can always say something like, oh, we see a lot of his patients. And then I say something like, a lot of people like him. Yeah. Okay? And that's true, a lot of people do. Of course, a lot of people like professional wrestling, too. So, I can always say something nice about somebody else's doctor, and you're smart, you're wise.
Well, there's a paper coming up a little bit
Don't
further.
make bad comments about other people.
There's a paper coming up on that about what to do, how to deal with people who have been harmed by some other doctor.
Before we do that, though, I want to go back and revisit the issue that the older the internists get, the dumber they get on the test taking. And the truth of the matter is, the older you get, the further you move into practice, the more removed you get from a lot of the esoteria that is covered on some of the tests. I do think emergency medicine did a pretty good job in that when you take your first set of board examinations, there's a lot of pathophysiology type stuff on there. When you take your recert exams, it's much more clinically oriented because that's what we do. I don't think any of us need to know what the Krebs cycle is anymore. But you did need to know that to get out of medical school.
Yeah, by the way, if I asked you, how many people here actually think their biochemistry is better today than it was the day they finished their biochemistry course?
And we're not talking about your ability to metabolize some substance.
Yeah, right.
We're talking about your knowledge of metabolizing.
Yeah, your knowledge base. You know what? God help me if I ever had to sit and take my biochemistry exam again, because I just couldn't do it today. That doesn't mean I don't have a lot of knowledge and information, but it is a different kind of knowledge base. There's no question about that.
I still think you have to go to Billy's original comment, which is you got to go back and look at outcomes, not just how people do on tests.
Right.
So it'd be very cool to know whether older doctors get sued more, because that would be the outcome kind of thing. It's a pretty crude outcome because you know that suits represent a
you have to
really...
adjust it for number of patients seen and all kinds of things, so it would be very hard to adjust it appropriately.
Lawsuit is not outcome-based.
Yeah.
Thank you.
Yep.
That's
then we
not
have
what
these,
it's about.
These papers here, and Rick started talking about them, where they talk about your relationship and your communication skills. And one of the things, I think everyone here has heard this before, but if that communication and that relationship breaks down, the chances that the patient will sue if there's a bad outcome go up dramatically. In every series that's ever looked at it, an angry patient that has revenge on their mind or wants to teach the doctor a lesson, you know the saying, right? You can always tell a doctor, you just can't tell them much. And so they look to actually tell the doctor something. They see the lawsuit as a way to communicate their anger, and so that's why good communication skills. And all these papers, if you look at 6 and 7, talk about it and say that when things break down and the patient's angry, you're really, again, you've never won an argument with a patient.
Well, 6 is basically says, do prior lawsuits predict future lawsuits?
Yeah.
Yes.
And the answer is yes, they do.
Yeah.
There's a problem with that paper, and that is if you work in a high-risk area, there are certain
OB,
areas...
high-risk OB.
Right, areas of the country, even, or geographic areas. They're Detroit or actually there's South Philadelphia. They're very, very litigious people. If you continue to practice there, you're going to have more lawsuits than...
Yeah, but you do it on a regional basis.
this is every-
they do it region by
This
region.
is all the doctors in Florida.
And by the way, let me tell you the spread in the United States. I've been president of 2 malpractice companies, and I was at the insurance meetings a few weeks ago in Chicago. If we're going to sue anybody here from Florida, yeah, we have to, of course, why would they come here? We'd have to get $26.80 a patient to cover the malpractice in Dade County this year. We have to get $26.80 a patient. In South Dakota, it's $1.60, and we're over-reserving. Now, why is that? Because the suit rate in emergency medicine suit rate in Florida is 1 in every 6,000 visits. In South Dakota, it's 1 in every 64,000 visits. Why? It's the mentality. In South Dakota, people like their doctors, and they are appreciative of the health care. And more than that, you're only the second most important person in town in South Dakota if you're the doctor, because the most important is who? The vet, okay? Because you can always have more kids, but good breeding stock's hard to come by. And they rarely sue the doctors. And so it is highly regional. It is highly regional.
This looked at a bunch of, this looked at 20,000 physicians. So this is a large study, so that, and largely primary care kind of thing, but, and this is not the only one. This is just a paper that says the more you've sued and be sued in the past, the more likely you'll be sued in the future. And I think it's one of the reasons when you get re-credentialed at your hospital every 2-3 years, they want to know about your lawsuits that it transpired, and they're going to make some kind of judgment about whether these suits are, red flags kind of things, or are they kind of benign, or those kind of, because that comes up all the time. You still go
with what Billy said, which is if you're high risk, look at it this way. When they looked at there was a big study they did where they looked at the cardiac surgeons, and they wanted they're posting all their data, and the one cardiac surgeon had just horrendous outcome. Highest mortality on the whole list. And everybody said, my God, throw that guy off the staff. And only it turned out that this was the guy that got the case, the toughest of the tough cases. He was actually the best of all the surgeons, but he got the toughest cases. You got to take that into account if, where you're practicing, not only geographically, but what you're practicing.
So it's clear, the high-risk OP people. I like the next paper, 7, which talks about patient complaints and says that, and they look specifically at unsolicited patient complaints. And basically what this paper says is we got to call a spade a spade. There are bad apples in there who push everyone's button, who have a lot of complaints. And in this one, more than half of the complaints involved only 9% of the physicians. And risk management files were opened based on based on a belief that an incident could lead to legal action in 504 of their complaints. Of the physicians, 35% had only 0 or 1 complaint and no. So there were the good people with no complaints, and very few risk management actions opened. There was a group in the middle, 1 or 2, and then there was this group of bad apples who had many complaints against them, unsolicited letters to the hospital administration saying, I got a problem with this person. And so this kind of speaks again to the fact that some people are sort of, and I think that one of the messages, I don't know if the panel would agree, that comes through here is that arrogance is perhaps the Achilles heel of medicine.
Oh, no question. I think that if you looked at those people, there are probably some spectacular clinicians in there who are just absolute jerks. There's a number, especially when you get up in the high-end specialists, there are pediatric cardiac surgeons that are phenomenally talented, but the hospital will not let them talk to the families. They have an intermediary that goes between them because these guys are just so abrasive.
The best interventional cardiologist at the private hospital they work at is a complete prick. But if I had to be stented, I would absolutely want him doing it. I've been in the cath lab with him when people were coding, and I know exactly what he's capable in terms of his hands-on, but he's a prick.
By the way, I don't want to give the pricks too much leeway here. And one of the reasons is you can be a perfectly excellent doctor and a perfectly nice guy as well.
Yeah.
It isn't one or the other. And the smart doc
I agree.
has learned how to get by. And I'll tell you, in the state of Michigan, 7 years ago, before I stepped down from this, I had my name on the bottom of more ER contracts, and I'd hired more residency-trained, board-certified emergency docs than anybody in the state of Michigan. I had also fired more residency-trained, board-certified docs, and I will tell you, I never fired one of those guys based on their knowledge base, not one. But you know what? When the administrator comes down to me and says, here's the 42 complaint letters, and by the way, the last person this guy treated was on the board, and he was a jerk. And by the way, if you don't take care of them, we will. That's what happens. And I mean, that's just the reality of the world, and we need to deal with it. And I'm in business, and I understand that.
But I think the other thing is, I would be willing to bet that most of those people had not only complaints from patients, but complaints from the medical staff.
Absolutely. Because they didn't know how to handle them. We were the largest user of the Dale Carnegie course in Ann Arbor. And over the years, I only had 2 people who were actually sent back from Dale Carnegie saying that they were psychological no-codes. We could not fix them. Okay? When Dale Carnegie says, you're an asshole, get out, I mean, you've got a serious problem on your hands. Yeah.
So those of you, some of you are ER directors, and if you're not an ER director, these physicians will affect you because if we, where I'm in Los Angeles, our malpractice rates are spread out between all of the doctors. So if one doctor gets sued, the department's malpractice rates will go up, and if 2 of them get sued, it doesn't affect them as individuals, it affects the entire group. So your colleagues are the ones who are determining how much you're going to be paying per patient to see these cases, and so it's clearly it suggests that where there is smoke, there is fire.
Absolutely.
And I have had graduates of our program who have gone on and they've had some. I mean, anyway, every day we go to work and stand on the railroad tracks and say, "I hope I don't get hit by a train." And someone would say, "Get off the road." No, that's the job. You go stand on the railroad tracks, and so some stuff's bad down the line. So sometimes you're going to sue because you were there. Sometimes it's going to be because of these other things. But I have a couple of people who I know who are out who we trained, who now I'm getting letters from credentialing offices and hospitals saying, I'm not sure we can insure this person because one, they had 1 or 2 bad outcomes, and then they might have had another thing where they loggerheaded. So now it's 3 strikes. And so the unfortunate thing is that as capricious as the legal system is, once there's a couple of events, it starts becoming career-threatening.
Yeah.
He has some graduates from his program who are unhirable. Their careers in emergency medicine, which could have been fabulous, are functionally unhirable because of all of the stuff that they have attracted over a relatively short period of time.
By the way, in my role as president of insurance companies, we don't care why you get sued. I just want to be real frank. I don't care whether you're stupid. I don't care whether you're malignant. All I care about is whether a piece of paper comes in. And when the pieces of paper keep coming in, you could be the greatest doctor in the whole world. We're just not insuring you. And the new technique, and let me just let this out right now. If you don't like big groups, just understand this. The new hammer of the big groups to take over small groups is we'll cover you under our insurance. because quite frankly, the insurance market is drying up in emergency medicine. It is a very difficult market. And so this question of insurability, getting your guys insurance, is going to become more and more an issue. And you know, if you've got somebody with a behavior problem, fix it. Because the insurance company sees enough of these letters, they're going to call into question the insurance.
You know, I know a director of a large multi-contract group. They have 60 contracts. And he said, you know, I think we need to create some kind of program for dysfunctional emergency physicians, because your career is related to how you interact with people.
Absolutely.
And there's no program that I'm aware of where you could send a doctor who's kind of got a lot of rough edges.
Henry and Little take care of that.
Would you beat him up?
Yeah, we beat him up.
But it's really not about avoiding malpractice. It's about developing some of these skills that will allow you to have a fruitful career for the rest of your professional lives. And there are doctors who are in substantial jeopardy that they are basically are not going to be able to work.
But it's amazing that they got out of a residency.
Yeah, but the great tragedy is perfectly good guys who are perfectly smart and perfectly reasonable doctors are limiting themselves by falling into bad practice patterns. And I think to a very great degree it depends. Some residencies are willing to let you get away with that, and I know others that won't. They actually step in and they do interventions with these folks, and I think it varies tremendously residency to residency.
Yeah, I'm not surprised by that at all, having run a residency for 10 years. That there's very differing focuses in training programs and the amount of activity directed towards this. In fact, while the ACGME has established these core competencies, and one of them is professionalism and sort of that deals with some of these interpersonal and communication skills, the teaching and education of those materials in residency is by no means codified. And what constitutes effective transmission of that information to junior doctors in training is not clear. And I think that the things that we're talking about reflect the fact that we may have focused a lot on how to teach people how to relocate shoulders. We haven't taught them how to relocate their personalities.
Do you know where junior doctors learn their behavioral techniques? From senior doctors. It isn't what you tell them, it's what they watch go on by their attending staff and the senior residents and things like that. They will behave exactly as they are empowered to behave. And if they don't behave like gentlemen, ladies and gentlemen, it's because they haven't watched that go on. Just listen to some of the discussions that happen. I mean, they are really not polite discussions. And I think that's unfortunate, because when you get out, 5% of our people practice at a place with an emergency medicine residency, 5%. That means 95% do not. And so they're going to have to learn a different set of skills.
So moving on, we'll go on to, now that it is acknowledged that mistakes occur, there's all of this issue now about full disclosure and the conflict between full disclosure and the stance of your insurer, because they're not into full disclosure. And so there is this problem that's coming up. Number 8 is what to tell a patient who's been harmed by another doctor. And there are a couple of interesting things in here, because you've all seen people who have been harmed by another doctor. And if you start getting asked questions about that, there is this issue about, you know, the AMA basically says full disclosure. Full disclosure is recommended by the AMA's Council on Ethical and Judicial Affairs. They suggest, however, that if there's another doctor that you are aware of who has harmed a patient, that before you talk to a patient about that, and this is probably more appropriate for primary care doctors, that you give that doctor an opportunity to discuss with you the case, because it's only fair that they have an opportunity to say, well, here's really what happened, or this is why it went down like it did. It's only a fair thing to do before you act as a Monday morning quarterback in these cases.
Yeah, I think that carries a lot of risk. Before you embarked on that path, you better be damn sure of what you're doing.
And they also suggest that you may even want to have that doctor present when this discussion goes on. I can tell you at our hospital, these discussions regarding errors occur where they're chaired by the hospital's risk management person, but they get a number of people in the room. The family members are in the room. They get these other people there, the nurses and those kinds of things when there's a mistake. And it's a very painful process, but these hospitals are going to full disclosure. Catholic Healthcare West, of which our hospital is one of their 42, Their policy is full disclosure now, and it is painful.
One of the things that was mentioned by Neil Little, who does some work with Greg, about disclosure is that one of the problems with not disclosing error, there are many, I mean, there are ethical issues as well, but from the insurance standpoint, one of the issues of not disclosing is that the patient has, in terms of the limitation of when they can bring the suit, the patient has a time frame, usually it's 2 years from when they would know or be expected to know that what you did caused the problem. If you don't disclose the error, then the statute of limitations does not exist. And so that any protection that you had from time, letting the case elapse, without full disclosure, the patient can bring the suit at any time, saying, I just learned of their error, and so now is the first time that I connected point A to point B to realize that I'm limping for the rest of my life because somebody messed up my knee. And so one of the insurance industries, although the insurance industry doesn't want to provoke a lot of cases with disclosure, there's also concern within the insurance industry that failure to close prevents statute of limitations from ever expiring.
Absolutely. The statute tolls when they, and here's what the law says, when they knew or should have known or should have been made aware of. So if you can document on such and such a date, we carried on this kind of discussion, and that's in the chart, you know what? That's when the statute starts to toll. And I think that to kind of let that stuff lie in limbo there is, first of all, immoral, but secondly, it is not in your long-term best insurance interest.
Well, these papers will also say it will make the patients very angry when they find out that you have hidden this thing, so that you've created an angry patient. Angry patients are the vengeful patients. And this whole process of full disclosure is not very old. Paper number 9 there is the paper that has suggested that full disclosure from a business point of view is not a bad idea. This is where they took the VA case. Go ahead.
We had some discussion where you draw the line. What is a problem to initiate full disclosure? Discussion, and I'm not exactly sure what you guys are talking about right now, the type of cases that prompt your institution to say this is a full disclosure.
I think it's disclosure of anything you did that resulted in some outcome. So you asked for one IV, the patient got 2 IVs. I don't feel compelled to say you need full disclosure that you got a second IV, we made a mistake, I only ordered 1. That's not what we're talking about. We're talking about an error that creates a problem.
How about a patient?
I don't agree with that, because at CHW, they will do a full disclosure if your patient was given the wrong medicine. There was no harm, no foul, but the wrong medicine was given.
Documented hypoxemia during conscious sedation.
Don't know.
Well, no, but that's not an error. That is part of the care of that patient.
It's a process.
That's a process. There's a difference.
It's not supposed to happen.
No, yeah, but yes, it is. It's supposed to happen about, depending on the study you look at, between 4 and 15% of the time. So that's a known thing that can occur with that process. It's like a headache after a spinal tap. Is that a problem? Well, you're not supposed to get a headache, but it's going to occur a certain percentage of the time. That's different than you had the hypoxia, nobody recognized it, and now the patient's a vegetable.
Okay. Everyone agrees with that, Dr. Henry? Hypoxemia during conscious sedation? Okay.
I think if you have significant hypoxemia during the procedure and you follow the usual and customary, activities, you're monitoring the pulse ox and doing all the usual things, I would certainly talk to the family afterwards about you experienced this during the process. I wouldn't walk in and beg for forgiveness and throw myself on the altar and say, oh my God, I can't believe what we did to you. I wouldn't start out like that. I mean, there is a certain sense of how you present the material.
Right.
But you know what? If you honestly speak about it, you can't beat an honest man. And most of the patients say this in all these papers. If they, doctors are humans. If something goes wrong, fine, tell us about it. But if they lied to us, I'll get them. That's what they're saying.
Right, but in that case, realistically, after the procedure, you're going to say, how did it go? Well, we had a little trouble with your oxygen, but otherwise everything looks, but we gave you, we put an oxygen mask on you, we addressed it type of thing. That's different than we did not monitor your oxygen And you know, when you weren't responsive, we put the pulse ox on you, and it was 50%.
Let me give you a case. We had a kid, and of course, it's a nurse's child. Came in with hives, and instead of getting 0.1 milligrams of epi, I mean, this kid was bad. Got 1 milligram. Now,
How are the hives?
It took care of hives like that. It was impressive. The child also had some chest pain. I mean, the child was 13 or something like that. Had some chest pain with this. And then we had to go in and say, you know what? They got 1 milligram and not 1/10 of a milligram. We'd like to watch them overnight just to make sure everything's all right.
I know a case just like this where a patient complained of shortness of breath in the radiology suite after getting a little contrast, and the radiologist gave them an amp of epi. Wide awake, normal blood pressure, no hives, no wheezing. The patient said, I feel, and so the radiologist, you know, with their knowledge and skills associated with the resuscitation of anaphylaxis, went and pushed an amp of epi on the person, who then developed ST depression and positive troponins and things like that.
Yeah.
That's an error. That's an error.
Yeah.
So,
There is a fine line, though, between an expected adverse. It's like, you know,
Which you already consented them for, by the way, when you consented them for your conscious sedation.
Yeah.
Right.
So we'd have to make a distinction between an expected side effect or negative consequence that we responded to appropriately versus a mistake where you got the wrong medicine kind of thing.
And that line blurs very easily. So I think for the purpose of the discussion here, though, let's keep it on the side of just an obvious error. You know, I looked at
With
your
an
X-ray. Right, I looked at your X-ray. I didn't see the pneumonia. I sent you home. You came back septic.
The 9 is the paper that said, from a business point of view, it might be better to have this policy of full disclosure, because when they did it in the VA setting, they found, yes, there were more lawsuits when there was full disclosure, but the total amount of dollars paid out was less when they had the full disclosure policy than when they didn't.
Yeah, you
Which might
understand?
not be
that
very
big?
compelling to the
Yeah.
docs, because if the docs aren't happy, even if, we don't care, because at that point we don't care. That's their money. We already paid them. We just don't want more of us to be named, because each of those namings and involvements is a substantial thing. So I find that the dollar value is less, but more docs were involved. A not very compelling argument from the medical side, even if the insurance industry thinks it's a win.
And VA patients are not, can you extrapolate that data to a non-VA setting?
Yeah,
Probably not.
You actually can't, because VA patients have to file under something called the Federal Tort Claims Act, which has a higher standard than almost any individual state. The federal government has so set it up that to sue them, you have to get their permission to be sued.
So,
And Abstract 10 says that acknowledging even minor mistakes, to your thing, they talked about even minor ones in Abstract 10, that just acknowledging them reassures people that, you know, when you ask patients about it, reassures them that you're being honest and forthright. And so it talks about even minor mistakes as being something that can be addressed.
In a microcosm of it, how many people will, if the emergency department's busy, you're running around like crazy, and you look up and there's a patient who you ordered the wrist X-ray on, you know, an hour ago, and they're still sitting there, and you go, what the hell are you still sitting here for? You go and look at the chart, and you know,
an elbow.
Right, or you didn't order the, you never actually flagged the order, you never put the order in.
Or you ordered on the wrong patient.
Yeah. Or and I go up to them and I say, listen, you're sitting here because it's my fault. I didn't get the order in. I just put the order in. They're going to move you to the head of the line. Don't worry about it. We'll get you taken care of. Patients respond to that. If you go up to them and say, hey, you know, I don't know what the hell's going on with these nurses here. You know, you should have been down there an X-ray hours ago. You're only going to wind up tripping yourself up.
Exactly.
People respond really well when you go up to them and say, listen, I screwed this up. It's, you know, but we're going to make it better. This is what we're going to do. They do tend to respond to that.
all these other papers here say patients unequivocally want to know about mistakes made. I guess it's all in how you go about doing it.
See, but it's also a lot easier to explain your actions than it is to explain somebody else's, which is, the patient that bounces back to you after somebody else took care of them, and then you come up with the correct diagnosis. It is very difficult to handle the question of, well, why didn't they see that the first time I was here? Now, sometimes it's very simple. Your symptoms didn't evolve that way. It looked like you had a urinary tract infection. it didn't look like you had a pregnancy in your tube at that time, whatever. It's much more difficult, or it's much easier when it's you were the one who saw them the last time, because you can say, this is what I thought you had, this is why we treat you this way, this is why, why we did it such and such a way. And most people are pretty reasonable.
I go back to my earlier comment. You never comment on anyone else's health care. We had a case where one of the residents is looking at a young guy with abdominal pain, and when we saw him, of course, he has pain at McBurney's point and rebound and all that kind of stuff, and no, he doesn't need a CT scan. He needs to go to the operating room. And he had been seen the day before at the university.
No appy harder than an early appy.
Exactly right. And of course, and the reason, and of course, the resident who's with me, a family practice resident actually from the university, said, well, you mean they couldn't even tell an appendix over there yesterday? I grabbed him, tied the knot on his tie so tight that his eyeballs bugged out. You know, it's not if you miss an early appendicitis, it's just when, right? It's a normal part of the deal.
And by the way, there's another med-legal thing that comes up with appendicitis all the time that I'm constantly talking to our residents about. So if you see a patient who looks like they have appendicitis, and they've got a lot of abdominal peritoneal signs and things, what you call that, if it's, they got a white count of 20, they're sick, they got a lot of peritoneal signs, you're much better off calling that perforated appendicitis than acute appendicitis. And the reason is that when you call it acute appendicitis, the clock is ticking to beat the perf. So you just put somebody on the hook, whoever your surgeon on call is, to get there and get it out. But if it really, I'm not saying to make it up, but if you call it perforated appendicitis, if that's your clinical impression when you saw it, now everyone's off the hook. The clock is no longer ticking. And this is one of the things that commonly comes up in acute appendicitis cases, where the surgeon it may not have been that they were, slack in coming in or ignoring their call obligations. It might have been that they were in the operating room with another case. And so calling it perforated appendicitis takes it off the ticking clock, if that's what your clinical impression is when you saw it. And so I'm always reminding residents, when they see a patient that looks that way, call it perforated appendicitis. Remember, that's your emergency department clinical impression. It's not a final diagnosis.
By the way, at Billy's place, there is no early appendicitis.
Yeah.
They've all been waiting there 6, 8, 10 hours.
Yeah, we joke that the test of choice for low back pain at our place is a urine dip. If they don't have large ketones, they've been foraging for water. They should have large ketones by the time we get to them with low back pain.
One of the other issues that comes up here is, should you apologize? Because some people say that really kind of nails it, that you made a mistake kind of thing, and never apologize, never waive the bill when there's a kind of a problem and say, listen, well, if you, we're going to,
I disagree with both of those.
I'm just bringing it up because obviously I don't agree with
17 states have passed I'm sorry laws. It needs to be 50 states. If you go in and have a heart-to-heart conversation with the patient, that should not become the basis of a suit. By the way, saying that you're sorry is not saying you're guilty. I'm sorry your child died. I am sorry your child died. That doesn't mean I did anything wrong. And to carry on honest discussion with a patient and then have it shoved up your ass at the time of trial is inappropriate. And so 17 states have done something about this. The rest of your states, in fact, ACEP in a lot of states has a model package, what they just had them put in, to the state medical societies to get them to go with this. But because you and I carry on an honest discussion with a patient, that should not be fodder for a plaintiff's attorney to shove back up our nose at some point in time.
And speaking of inappropriate is Abstract 16, which talks about medical errors that then become manslaughter charges. In other words, you make a malpractice, obviously we deal with life and death issues, they're medicine. If the patient dies because you made an error, when does it elevate to manslaughter charges? I'm a little bit sensitive to this because at our hospital we couldn't get dialysis done for a patient who I saw was a sickler with renal failure. She was in a lot of pain, quite sick. I saw her at you know how this goes, right? When did she come into the emergency room? 6:55 in the a.m. at the end of my 11 to 7 shift. So I saw her, medicated her with pain meds, put her on O2, IV oxygen monitor, and passed her on to my colleague saying, labs pending, pain meds on board. And of course, she looked a little puffy to me, and I noted that in my chart. She looks a little edematous, looks a little puffy around the face. She turned out to be in renal failure with a K at that time of around 6. Well, the dialysis people kept procrastinating. And they said, oh, she doesn't meet this is long after I was in REM sleep. They kept saying, well, she doesn't have any emergent criteria for dialysis yet. We'll hand her on the next thing. Long story short, it took them 14 hours to dialyze her, and she coded just as they were getting her to dialysis and died. The case was forwarded by the coroner to the DA for prosecution on manslaughter charges. So my name went in with that. So I'm a little sensitive to this. I think it's inappropriate for medical errors and system errors to be called manslaughter.
Well, not necessarily. There was a case at our hospital where one of the anesthesiologists was brought up on manslaughter because his supervision of the number of cases that were going on was considered to be so egregious. That they said this was well beyond malpractice. This was manslaughter.
But who made that decision?
Flagrant disregard for usual and customary behavior. That flagrant is the term they'll bring in.
But that gets thrown about a lot. Define flagrant.
Well, that was up for the DA to determine whether they were going to take this guy on.
Fortunately, in my case with the renal failure, the DA declined to become involved. And shockingly, as has often been pointed out in indigent care hospitals, there is this myth about indigent and poor patient hospitals that they're higher in terms of their risk of malpractice activity. In general, they're actually lower.
Yeah, that's
exactly right.
And no case was brought in that instance. And I was, we talked with risk management. I was worried about it. No case ever. Well, it's been more than 2 years now.
Yeah, but I think part of the problem is there have been a number of cases where these overly aggressive prosecutors looking to make a name for themselves have taken on that case. There was one fairly famous one in New York where they gave somebody 60 milligrams of methadone and they went on and died somehow or another. And they brought the intern up on charges, manslaughter charges or whatnot, and it clearly was related to political motives of the DA who was looking to make a name for himself as a champion of the poor type of thing.
Greg, have you ever seen any cases where physician fatigue was considered to be the cause of a screw up, and as a result they can go after the residency because you made that person work 36 hours, and as a result of that, we have all of this literature that says their skills deteriorate, et cetera, et cetera, et cetera?
I haven't actually seen a residency case, but I've probably seen 30 or 40 or 50 allegations where they said, doctor, how many hours had you been on that day? And so the places where they do work over 10-hour shifts, 12 hours, or some of the smaller hospitals, 24-hour shifts. I've certainly seen that brought in as an allegation and they quote literature, the plaintiff side quote literature that of course their performance was less because of X, Y, and Z.
Go back to 17 though, before you do the medical legal aspects of it. How many people have fallen asleep on the way home from a night shift?
Driving by Braille.
Oh, yeah. Exactly, those rumble lines. One of our doctors Monday night, following an 8-hour night shift, not doing a string of them, got in the car, drove home a mile and a half from home, fell asleep at the stoplight, foot came off the brake, crossed the intersection. Next thing she knew, airbags flying all over the place, head-on collision with somebody else. Fortunately, nobody was really hurt that badly. She was going about 20, the other guy was going about 30. But, I mean, that's the second doc we've had fall asleep after a night shift.
We have 18 residents per year, so 54 residents in emergency medicine. I ran the program for 10 years and have been in the residency office here for 15 years. And we have had at least a dozen accidents every year at the beginning of residency. And that's with duty hours. So we are strict adherents of the ACGME duty hour restrictions in terms of time between shifts, time off, total shift count, et cetera. We even monitor their outside moonlighting now. It's just a problem. I mean, it's often been said about emergency medicine, what's the worst thing about emergency medicine? And the answer is 3 a.m. What's the best thing about emergency medicine? 3 a.m. You can always make your point known at 3 a.m. Yeah. But it's the fact of the matter is it's a 24/7, 365 specialty, and working nights is hard. I mean, for me, I'll just tell you how I feel about it. Is one, I could do nights like there was no tomorrow. When I was 25, I could doing a string of 10 nights, 11 nights, I thought nothing of it. When I was 35, I started to not like it. When I was 45, it was like, holy, I need a full day recovery from a night shift. I mean, to think that I'm going to do anything productive in the next day is just a myth, let alone go back. It's just not the same. And it's hard. I mean, this is one of the realities of the specialty that nights hurt. And nights, I think, you know, you want to talk about currencies for fairness in any group. You know, is there a rational plan for how you're going to progress through nights as you get older is one of the important things. Is there a balance to it? Is there some fairness to it? Does everyone know what the night balance is going to be? And if you got a doc in your group, and a lot of groups have one that says, you know, I really like nights. I'm going to work all nights all the time. That doc is worth their weight in gold.
Yeah. I don't care if they drool. I don't care if they're blind. You know, the fact that he's willing to work nights. I actually work as an advisor to a lot of groups. I do business advisement as they're organizing. And 2 or 3 of the biggest issues we ever talk about, it's division of the money. What am I going to get for my duties as director or this or that? How are we going to divide up the money? And the next one is, how are we going to divide up the shifts? And so we've pulled a lot of this data about circadian variation and all this sort of thing. It's very clear when you're young, you can do it much more easily. As you age, in fact, I just finished a contract with a group in Florida, and I was the guy invited in to settle the war which was going on in the group. And so we have a progression now. When you get out of the residency, you start out working about 50, 60% night shifts. By the time you are 50, you work 0 night shifts. And you also have to then pass along and do more time in the urgent care, more time in their occupational medicine clinic. As you age, your practice changes with you, and I think that's right. I think that if you look at the police department, these are the guys who have to be chasing bad guys 24 hours a day. There's no 50-year-old cop on midnights, or very few. This tends to be where the young guys start out, then they graduate to afternoons, and they graduate to days. So at the end of their career, they've got day jobs and not night jobs.
We have in our residency now, just sort of by unofficial survey, out of 54 residents, I would say there might be 10 to 15 of them who are using ProVigil. So how many people have tried the ProVigil deal? Anyone here? Yeah. So ProVigil is...
Does it work for you?
It working? What do you think? Yeah.
There was just an article on it.
There's a no there.
Yeah.
What is it?
ProVigil, it's basically methamphetamine for nights. It's approved methamphetamine, but that's what it is.
It's
call it whatever you want.
There's just an article
methamphetamine for
in,
nights.
was it the Annals or Academic Emergency?
We just did our second paper on it. First paper was positive, second paper was so-so.
Yeah.
At best.
Let me tell you, by the way, there was a huge fight in Washington on this question when we talked about the limitation of residence hours. You think we'd taken the American College of Surgeons and we'd slaughtered their firstborn child. Well, how are you going to make real men out of them if they aren't fatigued and they aren't angry?
Continuity of care.
Continuity of care. I mean, this became crazy. And you know, the Libby Zion case in New York,
which led to duty hours.
Which led to duty hours. You can bitch all you want that it's not representative and it didn't speak to the right issues. But the truth of the matter is, it caused the conversation to go on, which drove the surgeons crazy. They couldn't believe it.
It didn't drive just the surgeons crazy, it drove everyone in training, because one of the things that happened was, what's your length of training? And so one of the arguments that the surgeons made was, now to be a general surgeon and to have enough surgical experience with duty hours, we're going to have to make residency 10 years long. And indeed, that was part of the discussion. In emergency medicine, the length of training wasn't that affected, and the reason is that most emergency residencies in the country were more or less in compliance with duty hours prior to this discussion, whereas almost all of the surgical residencies were not in compliance with duty hours, and for internal medicine, it was about half were in compliance. Yeah, the big issue for internal medicine was always their clinic day. Their clinic day would follow a post-call day. And so duty hours actually caused substantial problems in many, many internal medicine residencies around the country. And same is true for family practice, because their clinic day would follow a call day, and that would be a duty hour violation.
How many places did the residencies go to a night float? And people have that? Yeah, but our place did that, and it makes a huge difference. Night floats, I think, is absolutely the way to go, which is where it's not like you're on call every third night. It is you do an entire month where you are nothing but the night person. You know, there's 2 or 3 of you. You all come in at night. Everybody signs out to you, and there's great continuity of care. You know the patients from night to night. You're not trying to learn everybody that one night. They're much brighter. They're much more awake, alert. It's an infinitely better system.
Several papers in the EMA database on night float systems and the improvements.
It's very interesting that in the surgical discussion about continuity and length of training, so that nobody ever asked any questions about the health and welfare of the residents themselves and what kind of product would you produce. Would you really like to put out somebody who's chronically fatigued and angry at the world, or would you like somebody who sort of enjoys patient care? That discussion never came up.
Well, there's other health issues too with nights. It's estimated that if you do more than 6 nights a month, it's an equivalent to somewhere between 1 and 2 packs per day smoking in terms of cardiovascular risk. Ouch.
Yep. The other thing is, in terms of training programs, the data has become extremely clear that you need to sleep for 8 hours in order to absorb new data. You can absorb factual data, but what you can't absorb is concepts, and you have a very big time with dexterity problems. It's interesting, they bring up this scenario all the time. If you're trying to learn to play an instrument, you're trying, all day long you're trying to learn this set of chords on the piano, and you can't do it. Go to sleep, the next morning you wake up and you practice it and you do it perfectly. And that it's very clear that in order to integrate things in your brain, you need a certain amount of sleep time, and it's not in REM time either. So you may be having residents with less clinical exposure, but they're able to learn more of what they are exposed to.
By the way, pilots fly 80 hours a month. If they've flown for 8 hours, they must have a total of, 8 or 10 hours off after that. And I've seen them right at the airport where there's been a 2 or 3 hour delay. They've had to bring in another crew to fly because those guys would not hit the... And it's funny, we do that for pilots. Why wouldn't we do it to people who also have people's lives in their hands, which are the residents? I don't see that as valid.
These planes fly themselves.
Yeah, they do.
They don't need to be there, frankly, to take these things off and land them, They're just kind of chatting between themselves on the tape recorder. So that, frankly, they fly
something
themselves.
For the black box.
That's what it's, yeah, exactly. The truck drivers, now the trucks all have, you see these great UPS commercials about the person driving through the desert with the truck, the big 18-wheeler, and there's a desk in front of on the road, and they're stopping the truck and said, the packages say you're lost. Because the packages have all of these GPS things that they know where the trucks are, the truck's lost kind of thing. They're not allowed to drive anymore. Their logbook, they used to have a logbook about how many hours they drove. No logbook anymore. It's all automated. It's all GPS kind of thing. They're not allowed to drive, but doctors can work 36 hours.
The thing I find most interesting that I think hasn't gotten enough attention in circadian rhythm disruption and circadian blowout and the sort of professional equivalent of seasonal affective disorder is that we haven't done anything rational to address when our shifts change. It's very well known that exposure to 15 minutes of full spectrum sunlight on the way home after a night shift moves your circadian clock forward. You do phase forward adjustment with just 15 minutes of full spectrum light exposure. The point is that we should change shifts so that the person who's going home can get home in the dark, so that they can get regular sleep. And these changes, these are well-documented physiologic-based changes which we can do to our schedules to make sure that the person who's doing the nights has the least beating from them. And so some of the ERs that I work in have done this. They said, okay, we're gonna change at 6 in the winters, and we're gonna change at 5 in the summers, so that the night person can get home before the sun comes up. Just driving home. And I often tell the residents, by the way, having windows in your emergency department, which in some ways is obviously a good thing, but it's also a problem because the night person gets to watch the sun come up. And if they see the sun come up, they phase forward adjust. And if they're on another night shift, they won't get good sleep.
And we need to get home in the dark because some of us are killed by the light. Yeah. All right, come on.
All right. The last topic here, if anybody's beating you up about guidelines, most of these papers are fairly critical about guidelines and how they're developed and conflicts of interest. And I think that they're worth reading because there's a kind of a belief that guidelines are apple pie and motherhood kind of thing. This thing takes them apart fairly substantially with some good data and evidence.
It points out that when guidelines are written, they're twice as often to be used by lawyers as they are by doctors.
That's exactly right. You can buy a disc with the guidelines of all 24 of the major medical specialty societies right on them. You can buy that disc.
It has a biohazard sticker on it.
And by the way, almost no doctors buy it it's purchased by plaintiffs' attorneys. That's who buys it.
At AAM, I'm on this practice guidelines committee. They said, we want to come out with 2 good practice guidelines a year. I'm like, no, we don't. Why would you want to do that? What we want to come out with is our practice guidelines or things that refute standards of care, like the CAPE statement against steroids and spinal trauma, like the CAPE statement against lytics and stroke. Those kinds of things that provide a defensive posture are useful, but these guidelines that proscribe 20 actions for X, Y, or Z disease are a problem.
They're a problem.
There's no way you hit all 20 of them.
Although actually ACEP is doing that with right now they're coming up with quality measures for a whole bunch of kinds of things with, under the guise that if we don't do it, somebody else will. And there may be some truth to that.
In all fairness, there's a balance here. The board at ACEP did come up and pass, the council passed and the board supported discussion on 2 products, steroids and spinal cord injury and TPA and stroke. And we've used those. I literally have used the TPA and stroke protestations by the major associations in emergency medicine. I've probably used them 30 times in court. These things are important that the specialty societies go on record. When there's crap out there, stand up because you need to protect your membership. That's important.